I'd like to thank Dr. Landsman, Dr. Grieb for the invitation to talk to you about aortic trauma. I'm really going to focus on blunt thoracic aortic injury. And in 1996, over almost 16 years ago, in his presidential address, the American Association for Thoracic or Surgery of Trauma, Dr. Ken Maddox out of Houston entitled his talk The Red River Anthology and gave a nice sort of overview on the status of the treatment of blunt thoracic aortic injury at that time. For those who don't know where the Red River is, it borders between Oklahoma and Texas, and it's red because of the sands along the banks are colored red. And in this anthology, he made the statement that diagnosis was by aortogram at that time. Permissive hypotension was popularized. Immediate intervention was the mainstay for treatment with regards to timing. Disc-arch perfusion was beneficial when you're doing open repair to try to prevent paraplegia, which was a significant complication after these types of repairs. He went on to further state in his conclusions that intravascular ultrasound would be used for diagnosis and that stent grafts through the peripheral arteries could be used to repair these injuries of the Red River, quote-unquote the aorta, and that achieving these feats would be done faster and less expensively than in the past, and that the survival rates would be envied by the generation before. This led us fast forward to 15 years. Dr. Dimitriadis last year at the American College of Surgeons gave his scutter oration in trauma, talking about crossing the Rubicon and the management of blunt thoracic aortic injury, alluding to Julius Caesar in 49 BC traveling across the Rubicon, quote-unquote, the point of no return. And in this address, he talked about now, 15 years later, that CT scan was used for screening and diagnosis of traumatic aortic injuries. Delayed selective management was very important. Non-operative management was important for minimal aortic injury. TEVAR was replacing open repair, and that still there was an uncertainty about the long-term results of TEVAR, and he called for a national registry. These conclusions were based on the registry that was performed by that association, published in 1997 and 2008, and sort of was the mainstay of what we did in terms of the management of patients in our institution. So in general, blunt thoracic aortic injury occurs in about 0.4% of all trauma admissions to a level 1 trauma center. Interestingly, last year was an autopsy study done in Los Angeles of over 300 consecutive patients who had suffered motor vehicle collisions or dramatic falls, and a third of those patients had traumatic aortic injuries at autopsy. 80% of those patients died at the scene, and another 20% in the hospital shortly after admission. Now, if you translate this to the National Vital Statistics report published this year, in 2010, motor vehicle collisions accounted for 37,661 deaths. A third of those would then translate to over 12,000 deaths related to blunt thoracic aortic injury. Giving you an idea of the scope of this problem, that same year there were 10,397 deaths from aneurysms and dissections reported in that report. Thus, we all know about the mechanism, this acceleration, deceleration, injury. There are a number of other theories of how this occurs, but remember that 25% are due to lateral impact. Interesting report by Dr. Siegel and his group recently published both in 04 and in 10, working for the Crash Injury Research Engineering Network and analyzing using computer modeling to analyze sort of the forces involved in these injuries and to try to make recommendations to the Transportation Commission on Safety of Vehicles. They sort of analyzed all these injuries and ultimately, using finite element analysis, confirmed what we already know, meaning that there's a lot of stress at the aortic isthmus. But he did report in his study, his last study, that the aortic pressure can exceed or reach that of 1,300 millimeters of mercury, which I thought was interesting for that report. Now, again, that's a computer model. But he also talked about how the lateral injury could cause, or his theory of the lever effect, or lever arm effect which can cause these injuries, in that you have a lateral impact occurring, causing the heart and the transverse arch to rotate towards that side. The pressurized aorta becomes a lever, and the fulcrum of that lever is really the isthmus leading to a tear at that location. Again, this is a theory that he reported in his last paper. At any rate, diagnosis is made obviously by screening X-ray and CT angiogram. If there's any concern or suspicion of injury, then intravascular ultrasound and or angiogram is then performed. Our group, led by Ali Azizadeh, performed a nice study comparing CT, aortogram, and intravascular ultrasound, and basically defined that for equivocal CAT scans and intravascular ultrasound was the most sensitive test. Now, this ultimately led to the classification scheme for using intravascular ultrasound for traumatic aortic injury. Some of the advantages of ultrasound, obviously no contrast, no radiation, real-time accurate measurements, and giving you specific characteristics about plaque morphology, thrombus, and even calcifications. At any rate, the classification schemes is as follows. Grade 1, intimal injury. So these obviously can be managed most likely medically without any intervention. You have those grade 2, which are hematomas. And again, these are oftentimes treated with surgery or some kind of intervention. Grade 3, which are the false aneurysms, which are contained. And then the grade 4, which most of these patients die prior to any intervention. These are the free ruptures or die at the scene. One of the things about this grading system that you have to be cautious about is that the actual tear, and what I've experienced, the actual tear that you see in the operating room is much more severe than what you see radiographically. But at any rate, it does hold some validity with regards to how we manage these patients. We published our experience a couple years ago on blunt thoracic aortic injury, and it really came up because in 1999, Dr. Safi had moved over from Baylor and started the program there, and prior to that, there was a lot of cross-clamp and go for these types of injuries. So we wanted to see what our trends were and what has happened to our experience at that time. So in 1999, we started discharge perfusion as the mainstay for treatment for open repair. In 2002, the protocol added delayed selective management for repair, and then obviously the FDA approved TVAR in 2005. We started using TVAR for these repairs. Delayed selective management was really applied to those patients who did not have those grade 4 injuries, but had severe head injury, infection, burn, sepsis, contaminated wounds, and multi-system trauma. So admitted to the trauma service and the trauma registry we have at our institution between January 1997 and January 2012, 78,000 patients were incorporated into that database, of which 327 or 0.4% had the diagnosis of blunt thoracic aortic injury. There were 29 patients, 9%, who survived without any intervention. And a lot of these were minimal injuries, grade 1s, or really unsuspected injuries at that initial time. There are 114 or 35% who died within 4 hours of admission and couldn't get any intervention at that time. And then that left 104 patients, or 56%, that underwent some kind of intervention, open versus TVAR. So of the 184 blunt thoracic aortic injury patients who underwent a repair, the mean age or median age was 32. Most of them were men, and the mean injury severity score was 39. So a lot of these patients had associated injuries. Our technique for open repair really is a modified left thoracic abdominal incision. We do use disc perfusion, cannula in the distal thoracic aorta, heparin 1 milligram per kilogram. We don't use the CSF drain for these cases. My only comment really about this is making sure you clamp proximal of the left subclavian so that you can really include your tear within your repair. All our TVARs are performed in a hybrid endovascular suite. And of the 184 repairs, 29 or 20% were open clamp and go. And again, that was before 1999. There were 7 patients who required total bypass for really arch injuries. And then there were 77 patients, half of them who had open repair with disc perfusion. And then we've added 70, or come up to 71 patients who underwent TVAR, for the experience. So since 2005, 71% had undergone TEVAR for traumatic aortic injury. And as you can see here, the TEVAR experience has really increased as far as in comparison to the open repair. The overall hospital mortality for that diagnosis was still 41%. The operative mortality for any intervention totaled in combination 15%. Non-operative mortality, those patients who we couldn't operate on, mortality was 76%. So again, those are those grade 4 injuries that come in to the hospital. Looking at complications, mortality and morbidity, striking, really there wasn't a big difference between paraplegia and stroke, although there was 2 strokes in the TEVAR group. But mortality in the open distal aortic perfusion group was 14%, and you see TEVAR 4%, and TEVAR was significantly different from all the other groups in this experience. So delayed repair was employed in 35% of patients, and it was only associated with 1 death. And the mortality of urgent repair was 22% for this series. So looking at operated mortality, up through 1999, clamp and go, you can see here the operative mortality, in essence for open repair, 29 to 43%. Then we instituted distal aortic perfusion. The operative mortality was still quite high at 20 to 38%, but decreased a little bit. We employed delayed repair at that point. You can see the operative mortality going down, and then TEVAR, in which the operative mortality had dropped dramatically with a mortality reduction of 3% per year. But as Thor Sun taught us previously and mentioned earlier today, we as surgeons live in the numerator. And so you have to think about what's the actual denominator. Is this a selection bias? So we went back and looked at total mortality for all patients being admitted to the trauma center with this diagnosis. And thus you can see here 52 to 74% mortality for all patients with this diagnosis. We instituted distal perfusion, came down a little bit. We instituted delayed repair, came down more. And then you can see here the effect of TEVAR, although it's come up a little bit over the last couple of years. We've had more patients, but the reality is there was a mortality reduction for any patient diagnosed with this injury across the board, 2.9% per year. So we did have the denominator, and that's why I felt very comfortable applying this technology to these patients, even though our open repair had a good result. This is sort of the follow-up we use for our TEVAR, and really the crux of the issue here is that the compliance for TEVAR follow-up was only 32% in our patient. Again, this is a very difficult patient population to have good follow-up on. I'll admit our open repairs, the follow-up is really just a chest x-ray for a couple of years afterwards, and then they're free as far as I'm concerned because the reintervention rate is so low. Actuarial survival, all-cause mortality for open repair, you can see here, mean follow-up of 6.2 years out to 15 years. If they survive beyond that first admission, they actually do pretty well in this. This graph is almost flat. And again, remember, these patients are on average about 40 years old. You can see here with TEVAR, the mean follow-up is much shorter. We only have out to 6 years, and again, the survival is very reasonable, but I don't know what it's going to do 5 to 10 years out, especially in these younger patients. So what is long-term follow-up and how much is required? What is the long-term durability of these grafts, especially in young patients, 20, 30, 50 years out? Is this treatment really cost-effective? A lot of these questions are uncertain. At any rate, the SVS published this guidelines for TEVAR and trauma, and they suggested that the endovascular repair be performed preferentially over open, regardless of age, in their conclusions. So we have crossed the Rubicon River at this point, and there really is no turning back with regards to TEVAR in trauma, in my opinion. And I pull up this diagram because I noticed that obviously we know where the Hudson River is and then the East River, but there's actually a river going right down the heart of Manhattan, which I didn't realize. I did come to discover it's Greep's Channel and Landsman Canal. And this talk of waterway really made me look into Henry Hudson, who was an English explorer a number of years ago. Was an adventurer, came to the U.S., made several voyages from Europe to the U.S., came down the Hudson River, Hudson Strait, and went into the Hudson Bay. But ultimately, A mutiny occurred on a ship. They threw him out with his son and 7 other members, and he ultimately died in the Hudson Bay. So this makes me think of the reality, and what we're facing now is that we can be very enamored with a lot of this technology, but we cannot forget what brought us here, which is really all the patients we take care of. So in conclusion, blunt thoracic aortic injury still accounts for significant mortality. Patients reaching specialized centers of trauma can achieve respectable results with thoracic aortic repair. Improved early outcomes have been observed with delayed repair and TEVAR, and the long-term results of TEVAR need further study. Thank you very much.